India. And today we have an interesting talk on surgically remediable disease in children. I request our President Shafali ma'am to introduce the speaker for today, the moderator and the expert for today's session. Over to you.
Yeah, good morning, good afternoon, and good evening. Welcome to this webinar on, we have the session on drug refractory epilepsy. On talking about surgically remedial epilepsy in children is Dr. Ehsan Musa. And we're really privileged to have you here and lots of experts globally. Before we start, we'll just introduce the Congress. We have the 17th Asian Oceanian Child Neurology Congress, and we welcome you all to New Delhi from 17th to 20th September 2025. We'll be having some pre-conference workshops one a day before, and the registrations are now open and they will be mailed to you subsequently. Yeah, now we can come to the webinar, and Smita, you can show the slides. So this Dr. Ehsan Musa is globally renowned. He's a pediatric epileptologist at the Cleveland, Ohio, United States. And his area of his interest are epilepsy surgery. And he also works in ketogenic diet, which has really interested me. I was not very aware before that, Dr. Musa. We would like to collaborate much more. We've been working for the last 17 years on various, dietary therapy. So we love to collaborate. So, and everybody knows you. We're really privileged to have you. And then the experts, we have, as experts, we have Professor Ebru Arhan, who is a professor of pediatric neurology from the Gazi University School of Medicine, Turkey. And she's a co-leader of the pediatric epilepsy subsection of the Gazi University Pediatric Neurology. Her areas of interest are epilepsy, including dietary therapies and intractable epilepsy, neurostimulation, and sleep disorders, and has more than 100 research publications and has lots of achievements to her credit. And we are very privileged to have next slide, Smita. Professor Stanislas Legade, who's Associate Professor, Epileptology Department, University of Hospitals of Marseille, France. And he's our MD and PhD. His research areas are EEG, MEG, intracerebral EEG recordings, and has working extensively in the ILE, and has lots of articles and chapters, and experts in managing rare and refractory forms of epilepsy, and is involved in a lot of educational activities globally. And we have Dr. Krishna Prabhu. He's a senior professor and head of neurosurgery in the Department of Neurological Sciences, CMC, Vellore, Tamil Nadu, India. And really grateful to him for have joined. He just come out of the OT half an hour back, and he's done more than 12,000 cases of brain and spine injury. That's really amazing. Thank you so much, Dr. Krishna Prabhu, for joining. And for moderating this session, I requesting Dr. Sandeep Patil, who is the EB member for currently of the AOC in India, and consultant epileptologist and pediatric neurologist, director of pediatric epilepsy surgery program, Dinanath Mangeshkar Hospital, Pune, and runs the Epixa Epilepsy Center, has lots of publications, and has been working a lot on pediatric epilepsy surgeries and invasive EEGs, and also various drug refractory epilepsies. Dr. Patil.
Thank you, madam, for the introduction and introducing the speaker. This is this is a session what we are looking forward, and we don't want to waste the time. And I invite Dr. Musa to start his talk on drug-resistant epilepsy and epilepsy surgery. Dr. Musa.
Thank you, Sandeep, and thank you, Dr. Shifali, for the kind introduction. Thank you, everyone for joining for this session. Thank you for inviting me to give this talk here. And Dr. Shifali, when she initially approached, she asked me to talk about pre-surgical workup of drug-resistant epilepsy. I kind of made a counter offer to talk on the same topic with a slightly different title, surgically remediable epilepsies in children. And thank you for graciously accepting my request to change this title a little bit. Okay, I'm going to share the screen here. Make sure that the slide is coming there. I hope you're able to see the full slide without any next slide or anything like that. Okay. So the title is very self-explanatory. I'm going to talk about various scenarios of surgically remediable epilepsies in children. My talk is structured around these three basic questions we ask when we consider epilepsy surgery. Number one, is it needed? Number two, will it work? And number three, is it safe? If you approach any case, these are the three basic questions that you ask, and all your answers should be able to answer all these questions here. So my talk is going to be mainly structured around these three questions, and with probably majority of the talk is around the will it work, where is the epileptogenic zone, how do we select patients for epilepsy surgery. So going to the first question, is it needed? When you say is it needed, you're asking whether the seizures are really drug resistance, it is affecting quality of life. The definition of drug-resistant epilepsy was proposed in 2009 by the ILA task force, after some landmark studies by Brody and team, which suggested that a failure of adequate trials of two well-tolerated and appropriately chosen medications in right doses and right duration, if it is not able to achieve sustained seizure freedom, you diagnose drug-resistant epilepsy. And of course, one of the foundational landmark study that led to the foundation for this the definition of drug-resistant epilepsy was by Kwan and Brody, which is published in 2000 in NEJM. This study had a mix of both adults and pediatrics in children, adolescents, and 470 patients with various types of epilepsy. And the people who became seizure-free, 47% were seizure-free with the first medication, 13% were seizure-free with the second medication. And only of the 470 patients, only 4% were seizure-free because of the third and subsequent medication. This does not mean that the chance for seizure freedom is just 4% with the third medication. That's different. That's a different question there. It's probably the chances meaningful seizure freedom is about 15 to 20% with the third, fourth medications. And subsequently, there is a precipitous drop after that. And recently, the ILA Surgical Therapies Commission proposed, can we do surgery even before meeting the criteria for drug-resistant epilepsy? And I think many of you may be familiar with this. Let me minimize this window here so that I can. Okay. The video icons are kind of masking some of my slides here. So this Surgical Therapies Commission recommended that a surgical referral should be considered in patients who are could be seizure-free with one or two medications, but have a brain lesion in a non-eloquent cortex. So if you have a dysplasia, for example, in a frontal pole, patient, even if the patient is seizure-free, one should think about surgical options there. It kind of opens the door for a few, basically the long-term remission rate with these epilepsies are unlikely to be high. And that is the reason for recommending thinking about surgery much earlier. So before you jump to surgery, obviously, there are a lot of other reasons you need to think for in a patient with a drug-resistant epilepsy. You need to look for, rule out causes for pseudo-resistance. For example, the patient is on an incorrect treatment. A classical scenario is a trial of levetiracetam and oxcarbazepine in a child with an epileptic spasms, or for that matter, absence epilepsies. Those things are the not appropriate treatment. And incorrect dosage, it is not uncommon. By definition, if the dose is less than 50% of the WHO-defined daily dose, it should be considered suboptimal. So ensure that the patient has been tried on an adequate dose. And we have a lot of medications. We probably have 30 different anti-seizure medications that is available for use now. And should be aware and should be conscious about drug interactions, reducing the efficacy of these medications. You may be giving a good dose, but may not be having a good level, particularly an issue with first-generation anti-seizure medications that is still used worldwide, including developed countries. Non-adherence is an important factor, and other lifestyle factors could be contributing to this pseudo-resistance and misdiagnosis. And sometimes a patient could have epilepsy and non-epileptic spells, and the epilepsy may be controlled. These may be the non-epileptic spells that are continuing. So those things should be consciously thought about and addressed before you go to an epilepsy surgery evaluation. So in summary, for the first question, if the seizures are affecting the quality of life, and they are frequent enough, affecting the quality of life and truly drug resistant, by definition, 2 or more medications, but occasionally you could consider even earlier in a patient who is lesional non-eloquent location. And unlikely to have remission. Sometimes you could have a benign childhood epilepsy of childhood centrotemporal spikes. They sometimes could have a lot of seizures, failed multiple medication, disabling quality of life. But that's a syndrome that children would outgrow. We would not be thinking about surgery, especially in pediatric epilepsy surgery. You have to think about those options, those things also, not just failure of 2 medications. So if the answer is yes to all these 3, one should initiate evaluation for epilepsy surgery as soon as possible. Now, until a few years ago, the best evidence we had in support of epilepsy surgery. We know that the medications after the 2nd or 3rd medicines, the chance for success is pretty low. But what is the chance for success with surgery? This is one of the first randomized controlled trial in adults with epilepsy, the 80 patients with temporal lobe epilepsy, randomized to medical therapy and surgical therapy without any crossover. And surgery was clearly superior to medical therapy. The 58% had seizures, a reduction of or absence of seizures that impaired awareness after surgery, whereas only 8% were seizure-free, seizures with impaired awareness with medical therapy alone. And until 2017, we did not have this randomized control trial data in children. And this is a study from All India Institute with 116 children with drug-resistant epilepsy with a median age of seizure onset around 1.5 years, kind of typical pediatric epilepsy syndromes. And with surgical therapy, 77% were seizure-free at 12 months, and with medical therapy, only 7% were seizure-free at 12 months. We knew this all along. I think it is very good to have a randomized control trial data to support our decision to consider surgery in medically refractory epilepsy patients. So the first question we answered, is it needed? I mean, we had to make sure that the patient is truly drug-resistant, disabling seizures, and that is not something that children will outgrow with time. Those are the important features to think about it. So will it work? The question is, where is the epileptogenic zone? What are the success rate of this kind of surgeries? That's probably going to be the major chunk of my talk today here. When we talk about the epileptogenic zone, I think this is one of the beautiful definitions by Dr. Luders, where he highlighted the minimum cortical tissue to be resected or disconnected. I added the ablated and irradiated. That's why I said modified from Dr. Luders. That's my modification to become seizure-free. It doesn't matter what the epileptologist, maybe an expert who knows about epileptogenic zone, epileptogenic index, and say this area is very abnormal. But did it ultimately make a difference for the patient? So this definition is very patient-centered and patient-oriented, which I think is the most beautiful aspect of this definition of the epileptogenic zone. There are other schools of thought about the epileptogenic zone being the area of brain that is causing seizures, but ultimately, did it lead to seizure freedom? I think that's the key point there. So with regard to epilepsy surgeries, we basically use 3 tools for selection for majority of patients. Almost all patients, we do these 3 tools. And I recently reviewed our last year experience of selecting patients for epilepsy surgery in 2023 for an ILA survey. And I found that we had 78% of the patients we could do surgery with these 3 tools. History examination, which includes examination of the seizures and the semiology in particular, and a video EEG. Of course, EEG and semiology again comes here, and an MRI scan. These are the 3 basic tools for selection of patients for epilepsy surgery. Only a small minority, probably 20% in pediatric, and adults could be a slightly different numbers. You need more sophisticated testing, including intracranial monitoring and other things. So how do we select surgical candidates? I'm going to talk about 5 different scenarios. 4 of them are probably mainly surgical. The other one is probably non-surgical. And to highlight the various approaches and various case scenarios we come across. So this is case number 1 with a young adult with an automotor seizures with impaired awareness. Of course, we learned epilepsy surgery from the experience from epilepsy surgery in adults. And a classical phenotype in an adult would be what we call a temporal lobe epilepsy. This is a 28-year-old right-handed woman with seizures from 18 years of age, with semiology consisting of epigastric rising, panicky feeling, and then subsequently losing awareness, along with some orofacial chewing automatisms, hand fumbling lasting for 1 to 2 minutes. And this drug resistant. That's the EEG. Almost all the EEGs I show in this presentation are double banana montage with left over right temporal, left parasagittal, right parasagittal montage, unless I specifically say that. So this patient had a left temporal spike, and we recorded a seizure that is clearly left temporal and with a theta pattern there. And this patient had a left mesial temporal sclerosis. So the decision is usually pretty easy. Of course, we are talking about right-handed, and there are issues related to verbal memory and other things. But in most situations, in these kind of scenarios with a sclerotic hippocampus, the risk versus benefits are generally favorable to proceed with epilepsy surgery. So in this scenario number 1, you have a semiology that was consistently focal and an EEG that was consistently focal. And you have an MRI scan that is concordantly focal in these patients. So these are the most simplest of our epilepsy surgery cases. Okay, the left-sided one may have a wrinkle in this case, but in general, focal in all these 3 domains, the situation is generally straightforward in most situations there. These general rules are in adults are applicable for most children too. Probably 70 to 80% of children also follow these rules, but some children could have more challenging electroclinical phenotype. But the type of lesions tend to be different. In children, you tend to have large malformations, remote stroke, inflammatory causes, and so on. So this is a classical pediatric scenario here. A 12-year-old right-handed boy, he has seizures from 7 years of age and 5 years of epilepsy. He has multiple different kind of seizures, eyelid twitching, left arm elevation, so some right hemispheric signs. And sometimes he cannot hear for a few seconds. It's an auditory muffling of the sound, suggesting some auditory and perisylvian involvement. And the left body motor seizures with the tonic-clonic seizures. And his EEG showed a right parasagittal slowing and spikes. You can see some parasagittal spiking and vertex spiking. We recorded a clear seizures with the right parasagittal region. And that's the MRI scan. A serial MRI scan showed a progressive right hemispheric atrophy that was predominant in the perisylvian regions in Solano. So we are dealing with Rasmussen encephalitis. So typically seen in children, in young children, so to speak. But we start to see more in the adolescent and young adults also. We are seeing some rare cases of Rasmussen encephalitis. So if you look at this focal lesional causes of epilepsy, in pediatric, you can categorize them into hemispheric lesion. There are some classical ones that is listed there. I do not intend to go over all these things. And the malformative lesions of various natures, long-term epilepsy-associated tumor is the other big category. And focal encephalomalacia, due to a variety of causes, maybe a stroke or a head injury or a hemorrhage or a remote infection. Isolated mesial temporal sclerosis is not a common substrate we see in children. In a series of 50 patients from the last year, part of the last year, only 2 had a clear only mesial temporal sclerosis. Vascular malformations and other causes that is listed here and there. So we talked about focal, and we are going to make it a little bit more complicated in this scenario number 2 here. So this one was a 9-month-old child with epileptic spasms. I have masked this video a little bit, but you should still be able to see this. So So you saw a series of epileptic spasms with predominantly axial flexion there. There was some asymmetry there. As you can see, after each spasm, it becomes more and more intense. It's kind of a crescendo manner. The epileptic spasms were increasing. And that was the ictal EEG during the spasms. Unlike the popular belief that electrodecrement is a common phenomena, but the most common one is the delta transient. That was the EEG during the spasms. 1, 2, 3, 3 spasms, or you are seeing on the EEG here. And it is difficult to know where it is coming from. It is fairly diffuse. If some of you recognize some outer phase deflection in P8O2, that was consistent in this patient. Does it mean anything? We will see that. But this child had predominant focal spikes, which is predominantly in the right posterior quadrant. And we saw some spikes with an out of phase deflection and either electronegative or positive in the P8O2 region. And in addition, this child also had seizures with an ictal nystagmus. In fact, this was 9-month-old at that time, had spasms, had started seizures at 3 months with a focal seizure, and subsequently went on to develop epileptic spasms and focal seizures. This EEG is pretty clear here. This is a P8O2. This is a parieto-occipital seizures there. I think if you carefully look at it, you can see these EEG changes that is consistent with the nystagmus towards the left side. So right parieto-occipital seizure there. So we are dealing with a child with an epileptic encephalopathy and had some partial hips arrhythmia there, epileptic spasms, plus focal seizures. Okay. And when we looked at the MRI scan carefully, and her older MRI scan showed subtle changes of dysplasia in the right parieto-occipital region. And we could see the same area being hypometabolic on the PET scan. And this patient could undergo surgery and subsequently become seizure-free. It's been more than 8-9 years of follow-up with no seizures, no medications. So the use of epilepsy surgery in in children with epileptic spasms was not recognized until in 1990s. This was a landmark publication by Dr. Chugani from the California group there. They reported 5 children with epileptic spasms, and in whom they recognized an occult dysplasia by focal hypometabolism on the PET scan. Dr. Chugani and team were working on PET scan studies, and then they recognized a hypometabolic region, which looked relatively normal on the MRI scan. We are talking about a 1990 MRI scan. If you do an MRI scan in these children at this time, we are likely to see those abnormalities as a dysplasia there. Okay, but in 1990, the MRI wasn't sophisticated there. These children also had partial motor seizures, and the EEG showed localized and lateralized abnormalities that encouraged them to try surgery, and with good results. This kind of and opened the door for epilepsy surgery. And in fact, the original surgery was done for subtle lesions, occult lesions seen by PET scan. And obviously, there were children who had obvious lesions who were dismissed as not candidates for surgery, but subsequently the recognition that obvious lesions obviously can produce this. They could also be benefited with surgery. Again, the key point was they had localized or lateralized abnormalities on the EEG at that time. That's what this case scenario, even though you had a lot of generalized features on the semiology, EEG still showed low focality along with focal seizures and the MRI scan. So EEG and the MRI scan was very helpful in these patients. In the patient I showed, they also had focal seizures, but you may have children without any focal seizures. But if you see some focality on the EEG, you see if we can find a matching lesion on the MRI scan. Going to scenario number 3 here, this is an 8-year-old child with drop seizures and generalized EEG findings here. So this is an 8-year-old girl with a severe left hemiparesis, mental impairment with a 20-word vocabulary at 8 years, has refractory epilepsy that started in the 2nd year of life. And seizures included abrupt drop attacks with injuries, and she was wearing a helmet, 10 to 20 per day, and episodes of slumping over with unresponsiveness, head bobbing. So she had several features to suggest Lennox-Gastaut, not all the features. And that's her EEG, how her EEG looked like. And looks pretty symmetrical bilaterally, spike wave complexes, slow spike wave complexes. And this could go on and runs. More than 90 to nearly 100% of this EEG was showing generalized findings. But this child definitely had a right hemispheric malformation, and you have some clinical data to suggest left hemiparesis. And even though the EEG was absolutely unhelpful, this child could undergo surgery and subsequently became completely seizure-free with the opposite side generating normal rhythms. This is another scenario here. This is an infant with epileptic spasms. Okay. Again, if you look at the EEG, I do not know how many of you would pick a side based on this intrathecal EEG. This side is the right side, here left side. Right side is probably more on this page in terms of epileptiform discharges. And if you look at this page of the EEG, maybe right side is a little bit more healthier here. You can see some spindles here. Left side is more flattened here. Okay. So again, bilaterally equal abnormalities there. And this is an ictal EEG. This spasm here, there is a fairly diffuse burst of delta with an overriding fast activity that was happening during this spasm. This child had left MCA stroke-related epilepsy. That's what was happening here. And sometimes the area that is destroyed by this ischemic process may not generate as much spikes than the other side because of the epileptic encephalopathy. So sometimes the spikes may be paradoxically less on the affected side in these scenarios here. And this child underwent disconnective hemispherectomy, and that's the postoperative EEG. You can see the right side of the brain is completely healthy now. It's kind of, now the purpose of doing surgery in this is to make the right hemisphere do its job, and the left hemisphere, these findings after hemispherectomy are common, even in patients with seizure-free after the disconnective hemispherectomy. This is another scenario of a generalized discharge. A 9-year-old boy with moderate left hemiparesis, cognitive delays. He had what somebody would call as atypical absences, subtle zoning out with eye flutter, 50 to 100 per day, and video EEG confirmed several per hour, occasional falls with jerks. And you can see the EEG. EEG looks pretty active bilaterally. A little bit more darker on the left parasagittal region, which possibly meaning that there is an overlapping of the spike because of the higher amplitude. But the EEG was, the MRI scan showed a clear lesion on the right hemisphere, and he underwent hemispherectomy, and that's the EEG after the hemispherectomy. Again, we are rebooting the opposite hemisphere and saving the opposite hemisphere from the constant bombardment from the affected hemisphere here. These discharges are expected after hemispherectomy on the right side, on the affected side here. So this third scenario is mainly for generalized, a lot of generalized abnormalities. I think Dr. Wiley put this series together in 50 children with abundant generalized discharges. And some of them had discharges maximum on the opposite hemisphere. And they compared with 158 children who had predominantly ipsilational abnormalities. And again, 16 of the 50 had a Lennox-Gastaut kind of phenotype, 8 of them had hypsarrhythmia. All of them had congenital or early brain lesions, developmental or ischemic, that happened earlier in life. And there was no differences in outcome in these patients we operated on. So of course, everybody is familiar with the surgery for epileptic spasm. There has been reported from multiple groups across the world, French group, Italian group. And we also recently published our series of epilepsy surgery in children with epileptic spasms. The thing we wanted to highlight was the lack of need for invasive monitoring in these patients. So if you look at these studies, these are the 5 studies with a larger number of patients with epileptic spasms. This is a busy slide. I'm going to walk you through different columns here. If you look at the number of children with focal seizures, the study, this is our series from Cleveland Clinic, the one at the bottom. We had a smaller number with focal seizures. And if you look at the use of invasive monitoring for children with epileptic spasms in this series, it could range anywhere from 1/3 to 2/3 of patients undergoing epilepsy surgery. Whereas at Cleveland Clinic, we did none. Okay, we had 0. We did not exclude any patients who underwent invasive monitoring. We just included patients with epileptic spasms. And what is the result of this non-invasive approach? We could do surgery earlier on. Our mean age of surgery was much younger compared to the other series. And that was the reason why they did not have any focal seizures. It is very likely that many of these children in this series, they had a lot of spasms, did not have much focal seizures when they're younger. They were not operated. And they got older, they had more focal seizures than got operated. One may think that there is a difference in the radiological profile or the lesional profile. If you look at the number of lesions, we almost always operated in patients who are lesional with spasms. Even in these ones with a high percentage of invasive monitoring, the incidence of lesions is pretty high. So we, at least in our practice at Cleveland Clinic, we don't believe that many of these children with an epileptic encephalopathy with a focal lesion need invasive monitoring to decide our surgical strategy here. So in this scenario 3, we're talking about semiology that is not very focal, EEG that is non-focal, generalized, or sometimes contralesional maximum. And the MRI scan is the primary driver in these patients. And so that was helping surgery in these patients. So the concept of doing surgery in patients with epileptic encephalopathies was originally from Dr. Shugani. I think he opened the door. But the credit for completely demolishing this thing and making it widely available for a wider range of epileptic encephalopathies probably goes to Dr. Elaine Wiley, and our epileptologist at Cleveland Clinic, who unfortunately she recently retired from clinical practice, but she's continuing to be engaged in these activities, including her next edition of book is coming soon. So going to a 4th scenario, okay, no lesion on the MRI scan. So far, scenario 1, 2, 3, we had lesion, lesion, lesion. And the 4th scenario, we do not have lesion on the MRI scan. This is one of my favorite patients. I presented in multiple different talks. As a 17-year-old young man with no comorbidities, as a typical teenager, seizures from 9 years of age, he was having 10 to 15 to 20 seizures per day, both awake and sleep. And his seizures were described with some cold chills down the body, the feeling of emptiness in the head, and one of the striking features in his seizures is he would yell out a scream, like a blood-curdling scream, that could easily awaken everybody in the monitoring unit. Unfortunately, when he was admitted to our monitoring unit, he needed to be moved to different beds so that other people could sleep comfortably. So it was affecting his quality of life terribly. This is going to be an EEG video I'm going to show. So he's awake. That's when the seizure starts, at least the obvious features of seizure starts. He moves his head, he pouts his lips. So I think that loud scream, I don't know whether the audio came through during the presentation, and the loud scream was probably the most disabling aspect of his seizure. Sometimes he may do some automatic activity. Once he lifted a wheelbarrow when he was in the backyard and placed it somewhere else. So you could have some automatic behavior. I will skip this other video. As was during an ictal SPECT. So his EEG showed, it's a double banana montage here. It showed a left frontotemporal kind of a spike. You can see phase reversing across F3. You could also see some poly spikes in the same distribution there. And his ictal patterns were not that localized. You could see this is the time he's looking around. He's got a bifrontal distribution, definitely higher on the left side if you compare with in the temporal channels there. So we were seriously considering left frontal epilepsy. He had this ictal pouting or a chapeau, and which suggested involvement of the anterior cingulate network. Could involve the opercular and the insular regions too. So all the data was concordant, but he had no lesion. And we looked at the MRI scan carefully for these regions of interest. We could see a focal area of hypometabolism on the PET scan. And we did an ictal SPECT, which showed hyperperfusion in the same region. And a MEG was also showing the same region. At least, I don't know whether we would have a different approach if you see this patient now. But in general, non-lesional focal epilepsies, we tend to do invasive monitoring. So what I was highlighting there is 3 more tools for selection here, especially when you don't have a lesion there. PET scan, MEG, ictal SPECT. Again, not every tool is available for everybody. PET scan is probably the easiest one to be achieved because it's an outpatient intra-ictal study. SPECT requires a lot of coordination and expertise, and MEG is not available widely. So in this patient, because of this, our hypothesis about the right mesial frontal anterior cingulate prefrontal network, he had a fairly limited SEEG that is targeted to these regions. We were fairly comfortable with being very narrow in our approach in this patient. And that was this facial pouting there that you could see clearly there. And the L electrode turned out to be the main region of ictal onset. I'm sure Dr. Lagarde would be excited to see some invasive monitoring EEGs at this time. So when we placed the electrode, right from the moment he was in the OR, he had a constant continuous spiking in the L electrode mesial there. And that's itself is a marker for the epileptogenic zone, I think. So it's kind of fairly limited with any other involvement. That was where the electrode was. And we had electrodes in the surrounding regions. And the ictal patterns were also consistent. This led to a fast activity, again limited to that region, involving the lateral region, as well as it involved the adjacent part of the cingulate and the anterior mid-cingulate regions there. So this is the G electrode, it is right behind that, and the X electrode. Okay. So we were pretty, this is concordant with our pre-operative data, pre-SEG data. And we were comfortable that we probably have a very small epileptogenic zone. And if we offered a laser ablation, we could have easily done a resection, but we gave this option. If it doesn't work, we may have to make a bigger hole there. And that's what the laser ablation looked like. So he came back for follow-up, but 6 months later, he wasn't taking medicines. So he said, I knew that it's not, the surgery worked because he had 10 seizures the day before and none since the day of surgery. It's been more than, say, 7, 8 years of follow-up, and he has done remarkably well off medications. I believe that he had a depth of sulcus dysplasia that was not evident on the MRI scan. That I think that's what his epilepsy was. If he had done a resection, we would have probably confirmed the diagnosis, and that focal hypometabolism, the PET scan, was very, very instructive in this patient. So we are dealing with somebody who has got a focal semiology and a focal EEG with a non-lesional MRI scan. So most of these patients would require invasive monitoring. There are very rare situations, for example, a non-dominant temporal lobe epilepsy with classical scenarios, we might do a straight surgery. Almost all other scenarios, we do invasive intracranial monitoring when the MRI is negative. Again, when the MRI is negative, the EEG and semiology has to be helpful. I do not intend to go over all this semiological signs. So, of course, when the MRI is negative, you want to really maximize the information that you have from the semiology here. The thing I want to highlight is how much limited information we have when you have young children we are dealing with. Okay. They don't have the aura, sensory aura, visual aura. Good luck with that. Auditory aura, no. They have a reaction to all those things, but they may not say anything. Olfactory aura is missing. Bilateral tingling, pain, child cries for a lot of reasons. Ictal aphasia, ictal speech, young children, you don't have many of the signs. Even figure of 4 signs, the children had to be a little bit older to have this asymmetric tonic posturing. Unilateral dystonic you don't see often in young children. And then you have the epileptic spasm that doesn't help most of the time. See, it is much more, make it even more difficult to localize these children. So in young children, we work with a lot of limitations, but fortunately, most children, young children, they have refractory epilepsy. They have lesion that helps us, bails us out. Scenario 5, it's not specifically a case. The patient has got a generalized EEG and a generalized semiology and a negative EEG. They are usually not candidate for a resective surgery. Okay, for surgery to be resective surgery to be considered, you need to have a focality in one of these 3. If you don't have any focality, there is convincing focality in any of these 3 things, I don't think a PET scan or a MEG or a SPECT will make the case surgical. Okay. If there is a case like that, I would like to see how it evolved there. So in summary, the surgical candidates have focality in at least one of these 3. If all 3 are focal, concordant, easy case. If one is less, then becomes a little bit more challenging. And if no focality in any of these 3, a resective surgery option is not a possibility. So we talked a lot about lesion, ignore the EEG, ignore the semiology, go after the lesion. Doesn't mean that all lesions are same, okay? These are the list of the classical lesions we already went over. There are some lesions are not found in our series of early surgery. Subtle periventricular gliosis, subcortical gliosis, isolated sulcation abnormalities, symmetrical lesions like the malformation, lissencephaly, bilateral. We are not talking about surgery there. And tiny cortical, subcortical cyst, arachnoid cyst. Generally, we do not think that if there is an arachnoid cyst with a concordant focal epilepsy, you may have a different thing. But if it is generalized epilepsy, we don't think we generally do not approach them as surgical there. Malrotation of the hippocampus, most of the times they are benign and they are not the reason for that could be present in healthy children. With regard to seizure freedom after surgery in children, I think we have a few more slides here. It is generally very good. Of course, when you compare with the medical therapy, that is remarkably beneficial there. This is from the posterior quadrant surgery and temporal lobectomy in children. This is from hemispherectomy. 2/3 of patients after hemispherectomy are seizure-free. Sometimes this Kaplan-Meier curves make you a little underwhelmed about surgery. But if you look at the patients above this curve who had so-called recurrence, they are substantially better, especially in the pediatric. We have a dichotomous rule for this Kaplan-Meier curve, seizure-free versus seizure recurrence. They may have 100 seizures a day. Now having 2 seizures in a month is probably remarkably different in terms of quality of life for the patient and the family here. So that's the second aspect. Will it work? Where is the epileptogenic zone? How do we select patients in different scenarios? Is it safe? Now, once you decide that the epilepsy is coming from this region and can be safely removed without unacceptable side effect. Okay. There are some side effects that we may have to accept, otherwise we cannot do with the surgery, and it is unacceptable. Most of the times when we see the case and we understand what is the anatomy of the epileptogenic zone or a lesion, what kind of surgery done, you have a good idea what is going to happen. Okay, if you are going to operate on a healthy motor cortex, you are going to have motor deficit related to that region. So there's no rocket science about it. And pre-existing deficits is a very important thing. And they already have hemiplegia, then it is easier to proceed with surgery with the hemispherectomy if that is the case. Neuropsychological testing could also help us to decide what would be the effect. fMRI scan for atypical language localizations. Sometimes people delay surgery in young children, assuming that there is a language there that we are not able to study. Most of the times, if there is an extensive lesion, even on the left side, in a young child, if it happened earlier in life, generally they do not have language in that region. The opposite hemisphere is usually harbors the language. If you're able to do fMRI, great, and do a WADA test for language, that would be great. But most of the times, analyzing the case, understanding the location, and what kind of surgery we are going to do, pre-existing deficits, and the experience of the team is probably the most important thing. A month ago, I saw a patient who had a left hemispheric Rasmussen, a 5-year-old child with minimal weakness on the right side. And this child had a significant decline in language. And there was some hesitation in another center about doing surgery in that patient. So the diagnosis of Rasmussen was pretty clear-cut in that child. We recommended that if you do surgery now, it's very likely that the language will shift more effectively than you do surgery at 8 years or 9 years, waiting for the hemiplegia to happen there. If you don't operate, this is going to be progressive with hemiplegia. And it took some convincing for them to proceed with the surgery. And this child, after the surgery, was talking better on the same day. The language had moved to the opposite side in that child. So that comes only from the experience of the team. I'm glad to be working with a great group of people with a lot of experience in counseling this. So last slide. So 3 key takeaways from this talk. Epilepsy surgery should not be the last resort. One should consider early. Should consider it as soon as if you have uncontrolled seizures with trial of 2 appropriate drugs, and maybe earlier in some special situations. Generally, when epilepsy surgery is an option and indicated, it is usually the best option for seizure control. Sometimes the deficits may be unacceptable in some scenarios, but when the epilepsy is bad, many families are able to accept certain deficit. The child I was talking about, the left hemispheric Rasmussen, they were ready to accept the right hemiplegia, even though the child had only minimal weakness at the time of surgery, because this child was falling repeatedly with severe seizures. And the etiology, you expect the hemiplegia to happen later on. And I hope I convinced you that the surgical candidates have to have focality in at least one of these things, semiology or EEG or the MRI scan. If you do not have focality in all 3, then you're not talking about a resective surgical candidate here. With that, I will pause here and happy to answer any questions, comments.
Thank you, Dr. Musa, for the excellent talk. And I think you have covered most of the things. I think the important takeaway from your last slide was early surgery, right? So we still face delay in a reference. Like people kind of think of epilepsy surgery as a last resort. And I think it happens in Western countries as well. But it is more, again, in many anti-seizure medications coming in the market, the people kind of think of that, surgery is the last resort. Again, and taboo associated with the surgery as well. So what is your experience in your center? Do you have this delay in a reference, or you have the system in a place where patient who has a surgical remedial epilepsy immediately comes to Cleveland Clinic?
Of course, I think it is shifting, but if you look at the data from different parts of the world, there is a substantial delay in referral for epilepsy surgery, anywhere from 10 to 19 years, 10, 20 years of delay. It also depends upon the burden of seizures, how frequent are the seizures. Young children with frequent seizures, they probably seek out options quicker. Now the information is more available through the social medias and family support groups, so they are able to get the right services sooner. They're able to reach out. we get a lot of patients who are self-referred. This is not working. We want to consider this thing. So it is changing, but not sufficiently.
I agree because, many of the questions in the chat box and Q&A about the difficult cases, but we have so many simple cases which can surgically remediable, simple MTS or DNAT, and those has to be identified and referred to the center as early as possible. I think, I think we move on to our experts for their brief comment on the talk. Dr. Lagarde, if you want to comment on this topic overall.
Yeah, thank you very much. Excellent talk. I have the same answer, I think, for our center because it depends a lot on the setting for the referral of the patients. So in our country, most of the refractory epilepsy are early seen by neuropediatrician and refer to epilepsy center. So it's not a big issue in the children part, but for the adult, we see a lot of patients with less seizure burden and sometimes 10 to 15 years before to consult to the optimal settings. And a very important comment on the need to go earlier to the epilepsy surgery, especially in the young children. Also for the seizure outcome, but also for the cognitive outcome. We saw nicely in your survey in the Cleveland clinics, the nice outcome you have without any SIG in spasms with very young children. And we have the experience with the SIG recording, for example, in older children to see more complex networks. So perhaps there is some kind of epileptogenesis and more complex network with older children. So don't hesitate to refer early the children in such cases, I think.
Okay, thank you. Professor Arhan, you want to comment on the talk?
Yeah, thank you, Dr. Musso. It was an excellent speech, really, and you covered everything. Maybe what we have to say, and also I would like to thank Dr. Shefali and Dr. Hassan Tekil for giving me the opportunity to be an expert here. Yeah, this is really an important topic as we all epileptologists dealing with these drug-resistant epilepsy patients, you see that there's a really long journey of these people, these patients, children, and they come to you very late when the morbidity has overwhelmed the patient. Then therefore, I think there's a misunderstanding in the timing of the surgery in all pediatric neurologists. As Dr. Musa has also said, in Turkey, we are a middle-income country. We only have PET MRI and MRIs, 7 Tesla MRIs in Turkey nowadays. We have only stereo EEG in one center in Turkey, and we cannot do the stereo EEG that effectively. Therefore, and there are only a handful of epilepsy centers that deals with these patients for surgery, for epileptic surgery. Therefore, the number is not really enough for the whole pediatric epilepsy patients. But as a result, I would like to say that these patients should be referred to the epileptologist as early as they can be, to be really examined for the epileptic surgery considerations. And these may be with PET MRI. We use PET MRI mostly when the MRI is negative in the patient. If there's a hypometabolism in PET MRI and we go on those patients, we sometimes re-monitor the patients for choosing the lesion. Therefore, we have the pediatric neurologists should really refer these patients as early as they can to the epileptologists in our centers. Thank you.
Thank you, Professor Arhan. Now I will ask our expert neurosurgeon, Dr. Krishna Prabhu. Sir, kindly share your thoughts.
Thank you, Dr. Musa. That was an excellent talk. It was very straightforward, very clear-cut, and I think very easy for people to follow and understand the concept. from the neurosurgical point of view, I mean, I keep telling that, there are a lot of lesions that hang around in the neurology OPD, epilepsy OPD, or child OPD, and they just continue with continuous medications, and so the lot of cases, simple cases, I mean, leave alone the complex ones, the simple ones are not being picked up and referred to a good epileptologist and a surgeon. So that is what it's lacking in most centers in India, I think. Everybody, when they talk about epilepsy, everybody talks about talk about doing hemispherotomies, and so I mean those are all the high-end surgeries, and which can be done, but I think a lot of straightforward cases can be picked up, and so I think that's where the most important thing is my point. Number two is that if there is a chance a lesion is surgically accessible, that should be given to the patient, and the team should discuss and take it forward. We should not delay surgery for any reasons other than if it's accessible, if it's treatable, if it's easily accessible, I think we should go ahead, plan for the surgery and do it. I think, literature shows, we have enough proof, literature to show that early surgery has got a better outcome. So, thank you.
Thank you.
Dr.
Thank
Kothari?
you, Krishna.
Dr. Kothari, your opinion?
Yeah,
Sanjeev Kothari.
So, Dr. Musa, very nicely done. I just want to add a few more surgical options which we have available to us. Okay, scenario number one, you have a focal lesion sitting right on the motor cortex. You have a lesion sitting in the sensory cortex. There's no way you can excise that. We have now available with us responsive neurostimulation, where we put it over there, and it has done a fantastic job. We have a paper published on our first 20 patients that we did with remarkable success. Second scenario, you have a LGS patient who's on, I'm giving the worst scenario, felbamate, ketogenic diet, VNS, still having multiple episodes, not dropping to the floor. So I'm not suggesting calostomy, but what do you do? We now have bilateral centromedian RNSs placed in place with very good response when nothing else works. And we have found the VNS in combination with centromedian bilateral RNSs to be quite effective in this combination. I know that in adults, there is a trial going on, but this is our pediatric experience. So I think these are some additional areas where we need to explore more data with multicentric centers.
Yeah, I think
Absolutely, and
that's
neurostimulation is coming. Dr. Musa, please continue.
Yeah. I think those are the very, very important points. I limited my discussion to the resective surgical options. Neurostimulation, we are definitely learning more and more. And in fact, a lot of centers are exploring different options of the deep brain stimulation using RNS or the deep brain electrodes. So we're looking forward to more results and use that in practice. In our practice, we have kind of limited our neurostimulation to adult population to more than 18. This is not FDA approved for younger children. We can do it for compassionate purposes. So I do not have much experience in this RNS and the DBS in children. We do, of course, vagus nerve stimulator is widely practiced everywhere.
Have been doing, we've not been doing RNS, but we have been in DBS in some situations, but we have been doing a lot of TMS and for refractory focal ones. So that has worked. That has been working. We're doing TMS for many conditions, including refractory focals. It has been working. Dr. Hassan?
Thank you, Dr. Shefali. Thank you, Dr. Musa. Excellent talk. I really enjoyed that. And I would like to continue the Lagarde's comment. The epilepsy is a network disease, as well as in the focal epilepsies. So do you think in nowadays in the epilepsy centers, easily applicable this concept, epileptogenic epilepsy is a network concept on the surgery cases? I really enjoyed your scenario 3, children with epileptic spasm. Yeah. There is no focal seizures, so you didn't do intracranial monitoring. You applied to epileptic networks concept on this group. I believe in the future we are going to be more applicable to the epileptogenic network concept on the surgery cases also. And I think we a little bit underestimated to follow about the fibers and then DTI and the functional MRI studies to clearly define the epileptogenic networks, especially in the pediatric case. And also, there is another concept, epileptogenic indices in the epileptogenic area using the SEG. Do you think the SEG is more extensively used to define the epileptogenic networks on the brain for the surgical extractable areas?
Yeah, I think those are very important points. I think the network hypothesis is very well accepted. Even extremely focal epilepsies, there are networks involved.
Yeah.
We had a patient we discussed yesterday, had a constant spiking in the post-central sulcus, near continuous spiking, in a patient who has got a reflex kind of a seizure. And every now and then the spiking, when there is a higher amplitude, we could see it in the opercular region. It's very distant, but it is probably in the network, sensory network. The same way we have seen patients who have a bottom of sulcus dysplasia in the superior frontal sulcus, but their irritative zone, the MEG showing a tight cluster in the opercular region. So the epileptogenicity is in the superior frontal sulcus, but because of the subcortical tracts, the frontal ascending tract, the spiking is maximum in the remote region. So it is always a network. The patient I showed the L electrode, I think if you have carefully looked at it, there may be a network. If you have put electrodes in the insula and the operculum, you would have seen some spikes in that regions concurrently. So I think we are learning more and more about it, and we are able to apply it in a reverse manner. Earlier, there was a comment about PET scan and going back to the MRI scan. We almost always do. Whenever there is a focal information, new information, we go back to the MRI scan. PET shows hypometabolism, go back to MRI. MEG showed some focal dipoles, go back to the MRI. SPECT showed a prominent focally, go back to the MRI. When, of course, there is a non-lesional case, we try to make it lesional. That completely changes the game plan for the patient and the outcome for the patient. We're definitely learning more and more about this network, and I think the future is bright.
Can I just add a point on that? Can I just add a point? So, you know, somebody had put in the text about genetic testing. Yes, we all do whole exome and whole genome sequencing in epilepsy patients. But I think I would also suggest doing on the tissue that you get after surgical epilepsy for these genetic markers, because sometimes there is germline mutations or somatic mutations which may not be picked up in the blood. And we have picked up cases with DEBDC5, who it's a common genetic abnormality seen in the tissue with focal cortical dysplasias, and that changes the epileptic network, that changes the prognosis significantly.
Yeah, it's a very interesting approach also because now you can do such analysis on the tissue around the electrodes. There is some paper about that. So you can use the SEG electrode to have some information and some time to tailor or define the outcome.
Yeah. Thank you all experts for your beautiful comments. I think we have some questions in the chat box and in Q&A, but we'll take those questions after the case presentation. So I invite first case presenter, Dr. Kanda Kumar. Moderator is Dr. Lokesh Saini from AIIMS Jodhpur. Kindly be brief about your presentation and try to finish within 5 to 7 minutes so that we have some discussion about the case later on.
Good evening, everyone. Sir, am I audible?
Yes, Kanda. Yes.
Sir, are my slides visible?
Yeah. Your slides are visible. Go ahead.
Yeah. Good evening, everyone present here. I am Dr. Kanda Kumar, Senior Resident from the Department of Pediatrics, AIIMS Jodhpur. Today, I'll be presenting an interesting case, catching the tail from edge. So we have a 7-year-old boy from Bikaner who came with chief complaints of abnormal body movements for last 3 years. So he was a premorbidly normal child with normal development with right hand dominance who had seizure onset at 4 years of age. Maximum the seizures predominantly occurred during awake state. It was not preceded by aura, and the seizures had abrupt onset in form of tonic posturing of all four limbs, extensor posturing of left upper limb, and flexor posturing of right upper limb, followed by tonic eye deviation towards left side. And some episodes are associated with falls, but not associated with any urinary incontinence. The duration used to be between 30 to 40 seconds. These all seizures were brief seizures, and postictal confusion lasting only for few minutes, not associated with any postictal limb weakness. So let us have a view on some videos of the seizures. So in this, the child, it was not preceded by aura. The child had abrupt onset of seizure with tonic or dystonic posturing of both limbs, which was extensor on the left side and flexor on the right side, with neck deviation and eye deviation towards the left side. And this was a brief seizure which has lasted for less than 10 seconds. And after this, the child regained his consciousness, but there was some confusion for lasting for some few minutes. And this is one more video which was recorded during the long video EEG. In this, again, we can see there is an extensor posturing of the left upper limb, and there was some flexor component of the right side, and there was eye deviation towards the left side. And this was also a brief seizure. So almost all episodes had similar semiology. And in this, we can see there is some sort of a Fensar posturing, otherwise known as figure of 4 sign, and it has some localizing value. It lateralizes towards the lobe, contracted to the extended arm, and localizes to the supplementary motor cortex. And these seizure frequencies are quite high. He used to have some 8 to 10 episodes per day. And these seizures were refractory despite maximum doses of 4 anti-seizure medications, including oxcarbazepine, levetiracetam, lacosamide, and clobazam. And because of this high seizure burden, the child stopped going to school since last 2 years. And there was no history of any abnormal behavior, progressive cognitive decline, visual disturbances, excessive progressive tightness of limbs, paucity of limb movements, no extrapyramidal movements. There was no fever, trauma, or any acute vascular event preceding the seizure onset. He had insignificant perinatal history with smooth perinatal transition. There was no significant past history. He didn't have any febrile seizures preceding during his early childhood. And there was no significant family history. Developmental milestones were achieved at appropriate age in all domains. On clinical examination, he was vitally stable with normal general physical examination with normal anthropometric measures. There were no neurocutaneous markers, and the CNS examination was remarkably normal. So our hypothesis was this is an drug refractory epilepsy, probably a structural epilepsy without any comorbidities, with lateralization towards the right cerebral hemisphere and localization, probably a frontal lobe epilepsy. So points favoring right frontal epilepsy were the seizures were so brief and it had an abrupt onset. There was no aura and there was a fencing posturing and head deviation, tonic eye deviation towards the left side. And the postictal period was also very short and seizure frequency was so high. So we went ahead with ictal records. We had multiple, interictal records. We had multiple sleep and awake EEG records. Maximum in most of the settings, it was normal. Occasionally, we could find some spike wave discharges over the right frontal areas with normal background with preserved sleep markers. Then we went ahead with the video EEG. We had some five ictal events recorded during this video EEG. In this, I can't play the video, so I have made multiple epochs. So during this ictal event, in this yellow arrow, we can see some spike wave discharges over the right frontal area. And in the later half of the epoch, we can see a rhythmic buildup over the right frontal zones, followed, and this slowing has generalized over the bilateral hemispheres. And in between, there are multiple myogenic artifacts. And once the seizure has ended, the rhythm over the left side has come to the normal baseline, whereas right side, it took some time to normalize. So again, in EEG, we had some clear-cut ictal onset from the right frontal lobe. We went ahead with the MRI. Actually, this child had multiple MRIs done from the outside hospital and all were reported normal. So this is our in-house MRI. So initially, our area of interest were over the right frontal. over the right frontal lobe. So apparently we could not find any abnormalities in axial T2 and FLAIR images. But however, in this coronal section and sagittal section, we had some doubt over this area, over in the cortex surrounding this superior frontal sulcus. There were some gray-white blurring, but however, we are not sure. So we went ahead with the edge sequencing. This is edge enhancing gradient echo. So in this, this black line indicates the gray-white junction. If you clearly notice, we can see some blurring in the gray-white area in this focal region surrounding this superior frontal sulcus. And in this coronal image, we can see some transmental sign also. So retrospectively going to our routine sequences, we can now confirm our findings that there was a clear-cut gray-white blurring involving the superior and middle frontal gyruses along the cortex of this superior frontal sulcus. And then we went ahead with PET scan. In this, we can see some focal area of reduced metabolism over the right superior frontal gyrus. So our clinical localization, video EEG, MRI epilepsy protocol, and interictal PET, everything was concordant. So we went ahead with epilepsy surgery. Right frontal craniotomy with lesionectomy under ECOG assistance was done. Other tests like VARA test, functional MRI, ictal SPECT, MEG were not done in this child. So post-op histopathological examination, we can find, we found a cortical dysplasia, which is type 2B according to Blumke's classification. On 18 months follow-up, the child was seizure-free after surgery with the Angel's class 1A outcome. There was no residual focal neurological deficit. 2 anti-seizure medications were tapered and stopped, and child started to do his school education.
I think we can stop.
Yes, sir.
Okay. Any comments from experts, Dr. Musa, about the
Just I
case?
will.
Before that, Lokesh Saini will say he's the.
Yeah,
Lokesh, you want to
Lokesh.
add something?
So, like this is the one of the first case we've done in Jodhpur. So we are doing this lesionectomies at least because we don't have the facility of stereo EEG as of now. But well localized concordant lesions we have started doing, and we with a very good outcome. Almost once per month we are operating here pediatric cases with the help of adult neurology team, and all children have been benefited so far. So yeah, it's a very useful modality in selected cases.
Yeah, excellent case, Lokesh. And as I think Dr. Musa has mentioned in his talk, if everything is focal, then you have good chance, right? Any comments from experts?
Yeah, I think that's a great case. It's the depth of the sulcus of the superior frontal sulcus a little bit more anterior than I was initially thinking, based on the semiology. The left arm alone motor phenomena may be due to premotor cortex involvement also. It may not necessarily mean SMA involvement. It definitely, when it becomes bilateral, it definitely goes into the mesial frontal regions. And it is away from the eloquent cortex, and you have a concordant lesion, you have a dysplasia, you take it out. And intracranial monitoring is not required in these patients. And you could use, if necessary, you could do intraoperative ECOG because it's in the both banks of the sulcus, is the depth of the sulcus. Did you say type 2A or B?
The type 2B.
Type 2B.
Pathology. Yeah.
Okay. And the type 2B, the epileptogenicity is in the surrounding regions much more. The depth of sulcus dysplasia, you can do a very small, tiny resection and be seizure-free. In type 2B, we would like to have a little bit of margins to that. Okay, it's a case-by-case basis. It's away from the eloquent cortex on the right side. Great job.
Though MRI look. Sorry,
nice thing. The thing is, what we do in our center, we do stereo EEG even though we have a suspicion. I'm sure Dr. Musa does the same thing, because we want to find out the goalposts of the area of excision. So we go around that lesion, putting in stereo EEGs over there. So we know the extent of resection based on what we find.
So that is also one question from my side. So you and Professor Musa, Professor Lagarde, that in such a case, how many electrodes you will put for stereo EEG? Like if we have how many electrodes, minimum number?
In this case, in my opinion, most of us in our group would say do surgery straight away. So my recommendation is 0.
Yeah,
If it
I
is possible,
agree.
the motor artist may be different.
Yeah, it's true. Also because you can sometimes tailor a resection with the E-code, as you did, but you can also add some depth electrode acutely to record really the bottom of the sulcus and after tailored resections. Yeah. In the old ways we are doing, I would say, with 5 electrodes, but because we have the experience previously, now we stop doing SIG in such cases because the maximum of epileptogenicity is always in the FCD at the bottom of the sulcus.
I think in this case we can we see that the basic MRI should be examined very carefully because the first MRIs were normal, as you said, Dr. Saini, yeah. And the last one is really appropriate for FCD. And in our center also we use ECOG like you, and we don't have stereo EEG as I said before, and we use ECOG for the edge of the lesion, where to go, how much to go, and we use ECOG for that, for those lesions. Yeah,
we did the same.
It was an excellent case.
Very
I
nicely
think,
done.
yeah, if we see the MRI carefully, this bottom-up sulcal dysplasia was quite visible there. So I think,
yeah.
And in a country like India, I think we will avoid stereo for those cases.
So
yeah.
So like that. So why I want to highlight this case is like we have a suspicion, right, frontal from semiology, the EEG also. So the sequence edge helped our suspicion much, and without the stereo EEG, we were very confident that okay, we are dealing with this FCD, and we removed that. So
the sequence we like for that is the 3D T1 volumetrics with 1 millimeter cuts. That's the best one for that.
Okay, I think we can move to the second case now. It is from SIR HER Chennai. Dr. Aishwarya is a presenter, and Dr. Ranjit Kumar is a moderator.
Kanda, your certificate will be made to you.
Thank you.
Thank you for an
Aishwarya?
excellent presentation. Thank you for excellent
Can you-
presentation. Ishwar,
Thank you, ma'am.
Can you share the screen, Dr. Aishwarya? Yeah, it's there. Start presenting.
Yes, sir. A very pleasant evening to one and all. I'm Dr. Aishwarya, pediatric postgraduate from Srihar. Today I'm here to present an interesting case on the topic cutting ties with seizures.
your voice is breaking. Can you switch off your video?
Can you understand anything?
Dr. Aishwarya,
Aishwarya,
we have
please switch
trouble
off your
hearing
video.
you.
You switch off your video so that your audio is not clear.
The guidance of Dr. Ranjit Kumar, sir.
Aishwarya, we
Madam,
cannot hear you.
should we go to the next case, or Ranjit,
Yeah,
can you
Aishwarya,
present?
can you? Yeah. The next one can present, and then the previous one can try later.
We move to third
Yes.
case, Dr. Kavya from
Can I
SRCC
present?
Children.
Can I present instead of that? Like I
Okay,
think
Ranjit, you can present. Yeah,
Yeah.
please do.
Start.
he may be having some network issue. Yeah.
No issues. You present.
Can you see my screen?
Yes. Go ahead.
Yeah, so I will be presenting on her behalf. This is cutting ties with a seizure in a young girl. A story of triumph over epilepsy. So this is a 11-year-old girl referred to us for pre-surgical evaluation. Seizure onset at 3.5 years of age. Predominant seizure type, there were three seizure types described by the parents. Focal non-motor seizures with impaired awareness, absence like spells, and subtle head jerks. There were around 3 to 4 seizures per day, predominantly upon awakening from sleep. So child was already on 3 anti-seizure medications, sodium valproate, lamotrigine, and levetiracetam. She was having a regular good compliance. Previously tried on clobazam also, which was stopped due to excessive somnolence. Seizures continued in spite of taking regular anti-seizure medications. You can note she's on sodium valproate in spite of being an adolescent girl because they couldn't wean off. Her antenatal history was significant that although child was born normally, normal birth weight, she developed hypoglycemic seizures at day 3 of life. So this is one of the very common scenario which we see in resource limited settings, like probably due to several factors. Her motor development was nearly normal for age. So the parental concern here was they would not let her fall asleep during daytime or travel or even at school because these seizures happen upon awakening. So they would try to keep her awake. So they would let her sleep only in the night time. So, and also they were afraid of getting hurt due to subtle jerks and falls. And the side effects of anti-seizure medications, which can make her sleepy at the school, and the need to continue sodium valproate in spite of reaching early adolescence. So with this, we went ahead with the pre-surgical evaluation. So this is the MRI scan. So if you can see here, you can clearly, basically it's a case of a focal gliosis in the mesial occipital lobe on the right side. So you can clearly see there is an area of focal gliosis involving the entire right mesial, lateral, as well as even some extent of the posterior parietal lobe. And interesting thing to note here is, in India, we do extremely commonly see neonatal hypoglycemic brain injury, which causes bilateral occipital gliosis, particularly in the mesial occipital region. This case, it was unilateral. So this is one thing which epileptologists like, unilateral focal gliosis. And we can clearly see there is a well-preserved occipital lobe on the left side. It can be appreciated in the coronal sections also. It's a kind of a wide, extensive lesion. So this was her MRI scan. And just to rule out any arterial pathologies causing unilateral posterior circulation, strokes, MRA is normal. Somebody was commenting on ASL. This is the ASL image, arterial spin labeling. Although it's very difficult to interpret at a very given time point, you can see this is a mesial occipital lobe on the right, on the left. We can, when compared to that, on the left, you can see some degree of reduced perfusion, which can be attributed to the gliosis per se, or it could be due to the reduced hypometabolism secondary to the epileptogenic zone, although you cannot derive conclusions based on this. So we went ahead with the video EEG. This is what her EEG showed in an awake state. So we do an extended montage. This is the longitudinal bipolar with an extended montage. We apply T10, P10, T9, F9, T9, and P9 in addition to the standard montage. We can clearly appreciate there is a laterality towards the right hemisphere. You can see the amplitude maxima is over the right hemisphere, but it is generalized with the right hemispheric predominance. Although it's very difficult to localize which electrodes show the maximum phase reversals, or in fact, some of them do look like a frontopolar. So this was what Dr. Musa was describing. Even patients who are having focal lesions, when the epileptogenesis go into what we call as stage of secondary epileptogenesis, they can get generalized patterns. So this is one of the epoch during a drowsiness and sleep, and you can clearly see discharge is getting activated and becoming more synchronized, and very difficult to appreciate the laterality. But I would like to draw your attention here. You can see T10 and P10 region. You can see rhythmic, sharply contoured delta activity. That's what I feel is the maximum electronegativity in this generalized picture. So this is one of our epochs during sleep. So this is one of the absence, atypical absence, which we captured. And during that absence, she had also had subtle head jerks, which may be very difficult to pick up. So just for our residents, atypical absence is one EEG, one seizure pattern, which is very difficult to recognize both clinically as well as EEG. The only way we can appreciate is probably an increase in the spike burden and the patient zones out during the episode. So she is in the epilepsy monitoring unit. You can see she is showing some degree of facial response.
Yeah.
And now she is not responding. She is kind of zoned out. Somebody is trying to talk to her.
Hello?
She's almost frozen. And if you notice carefully, subtle head jerks, maybe you may not be appreciated at your end, very subtle head jerks are happening at the time. Maybe I will try to play that part while subtle head jerks are happening.
I will share it.
Yeah.
Hello?
That's a very subtle head jerk.
Yes.
If you look at the EEG here, it's clearly a generalized spike sharp wave activity, which doesn't show clear like laterality in this EEG. So it's more like a generalized pattern. So based on EEG is a generalized pattern. Based on interictal data, we feel the epileptogenic zone maximize over this region. So ideally, in a scenario like this, it is worthwhile to proceed with invasive EEG monitoring. So I would like to hear the comments from the experts. But in a country like ours, due to logistic reasons, due to cost and several factors, we are not able to perform in common situations. So invasive EEG may be recommended to further delineate the epileptogenic zone and define the margins and to clearly plan the procedure. So we also do genetic testing just to rule out any predisposition to hypoglycemia because she was not having intellectual growth retardation or any other factors which do contribute to her early perinatal insult, which was negative. Her neuropsychology assessment did not reveal any specific lateralization or localization. Her full-scale IQ was 46, which would indicate mild to moderate delay in intellectual disability, consistent with her epileptic encephalopathic pattern, which we saw in the EEG. So, and also having a lesion in the posterior cortex, we should evaluate her visual fields and perimetry. Ophthalmological examination was normal. She couldn't cooperate fully for a complete perimetry, although we expect some degree of homonymous hemianopia contributed to the affected hemisphere. So with this, so we have a girl who is having drug-resistant epilepsy. She has few seizure types which are not having a clear lateralizing value, and her EEG is kind of a generalized pattern, although it doesn't clearly localize to a specific region. We do have some degree of right posterior predominance, and the only clue here is a clear focal lesion on the MRI. So in this case, we always do a multidisciplinary team meet, looking at the risk and benefit of doing a procedure. So I would like to highlight the benefits of doing epileptic surgery in a patient with epileptic encephalopathy. It's like you prevent the cognitive speech and decline, you prevent your sleep behavioral issues, you prevent the contralateral diffusion of IEDs or secondary epileptogenesis development. In this case, it has already happened actually. And relapse of spasms later, even if the patient is having resolution of clinical spasms. And obviously, they've developed into subsequent catastrophic epilepsies like Lennox-Gastaut syndrome and long-term exposure to multiple anti-seizure medications. The only risks which are associated here are the surgical risks, which are often very minimal in experienced hand. And obviously, there is a transient worsening or permanent worsening of homonymous hemianopia because of either disconnection or quadrantectomy involving the optic tracts. So with this, we went ahead with the we explained the risks and benefit to the parent. And the parent went ahead with the option of which we suggested. So we went ahead with the right posterior quadrant disconnection with neuronavigation and neuroimaging guidance. The entire procedure was uneventful. Basically, they disconnect the parieto-occipital cortex from the rest of the hemisphere. So the diffusion of epileptogenicity from that region to the frontal and the temporal lobes are prevented. So like disconnecting the network. So the procedure was uneventful, very uncomplicated course, discharged very soon, and post-epilepsy rehab she underwent. This is probably not the one of the best cuts to show the disconnection. This is the immediate post-op next day. When the immediate post-op, you have a lot of edema, so you may not exactly see the disconnection, but just to see there is a disconnection tract, which you can see in this scan. So she's currently 6 months post-surgery. She's completely seizure-free from next day. No further neurological deficits. According to the parents, she is seizure-free, going to school regularly. There was no worsening of any visual deficits or anything in terms of visual decline. I asked the parents, how did the epilepsy surgery impact you? They said, we are extremely relieved as she can sleep anytime as per her wish. That was the best thing which they got out of this epilepsy surgery. So our plan is to repeat EEG after 6 months and taper off ASMs one by one, and IQ assessment and quality of life assessment. And this is our epilepsy center at Chennai from SRMC Hospital, and this is our team. Thank you very much for the opportunity, and thank you.
Thank you, Ranjit, for that excellent presentation. I think this topic is very close to all of us from India. The Pareto Hospital biosis and neonatal hypoglycemic brain injury. I would like to ask Dr. Musa, what is your experience about this condition in your center?
So we do sporadically see patients who we presume it could have been a neonatal hypoglycemia because of the bilateral occipital gliosis. I know it's very frequently talked about in India. They are frequently bilateral, as Dr. Manohar was saying, and if the patient has focal epilepsy that indicates one side, we have pursued surgical options in selected cases. I don't have any data about how they did and all, so we have not studied it, but I have come across these patients. But if it's unilateral like this, but by the way, congratulations, great case. The only disagreement I would say is it's not secondary epileptogenesis. It's just a network is being activated. There is no secondary epileptogenesis at this stage. You stopped it before it developing secondary epileptogenesis. It could be an occipital epilepsy with an occipitofrontal network being activated. Sometimes we have tried to do MEEG in this patient to see if there is a preceding occipital discharge before the frontal discharge. But sometimes you may not be able to sort all those things, please yourself by doing all this testing to convince yourself. You need to believe that the lesion is the driver and go ahead and go after the lesion. If you put invasive monitoring in these patients trying to prove that the right side, you may walk away from doing surgery. It might show more activity in the frontal and then say, okay, maybe this is not a surgical case. For that reason, we try not to do invasive monitoring in situations we think that the lesion is the responsibility. And the electrical features are more diffuse. The electricity is focal, invasive monitoring could be focal. If the electricity is diffuse, invasive monitoring is going to show diffuse activity. So in terms of the substrate and the outcome, I don't think I have data, but of course, anything focal, if you have electroclinical features suggesting focal, you could consider surgery.
Can you show us the genetic testing? You said whole genome, whole exome and mitochondria were negative, but there was some mention about the COL-G4, something there.
Yes, sir.
Was that real or was that just a whoos?
That was one of our suspicions. It's mentioned in the history.
I see. Yeah. Because COL4A3 definitely has an angiopathy, and we recently had a couple of occasions where we did an MRA to prove that they have that thing or not. That's why I was asking. But the question I have for the other panelists, I've never found a true answer, is why in neonatal hypoglycemia, the parieto occipital region is affected more. Is it the embryology of the blood vessels? But almost all cases are in this exact posterior circulation area, and really nobody knows why that happens that way.
Yeah. If Dr. Qatar has finished, yes, I also would like to congratulate you because we see a lot of cases of drug-resistant epilepsy due to hypoglycemia, but they are mostly bilateral, not unilateral. And we don't further do invasive monitoring for these patients. We choose palliative procedures for them, for example, VNS, not surgery. I congratulate you. Yes, going on.
Thank you.
Just Lagate wants to say something, I think. He's testing some.
Oh yeah, I have the same feeling than Dr. Mosa. Most of the patients we have seen with some hypoglycemia have bilateral lesions and sometimes with complex bilateral networks. But of course, we have some cases, as you a nice one, with unilateral lesions. And in these cases, sometimes SIG could help to tailor a bit the resection, but it doesn't change a lot the procedure. And for the posterior predominance of the lesion, I don't know. But in PET, we see that the maximum of the consumption of the glucose, most of the time in the posterior cortex, or perhaps there is some fragility of this cortex to the hypoglycemia, but I don't know. It's not comment.
Yeah, we have crossed time by 6 minutes. Can we go on for another 10 minutes? Because we had the last case, if it's okay. And Dr. Musa, if you want to answer any questions online in the Q&A, you can do that if you think something can be answered. The rest we can just take. So we can request, if permission is there, the last case to come in 5 minutes so that we wind up in another 5 minutes. Party,
Sorry.
the next case fast.
Yeah.
Is that
Yeah.
permission? Yeah.
Yes. So I think I'll just invite the next case presenter, Dr. Kavya. She is from SICC Children's Hospital, Mumbai, and the moderator is Dr. Pragna Gadge.
Good evening, everyone. Hope I'm audible. My slides are visible.
Yeah.
Yes. So good evening. Today I'm going to present a short case, which is an unusual presentation of a LIAC, which is low-grade epilepsy associated neuroepilepsy. Myself, Dr. Kavya, my guide is Dr. Pragna Gadge and Dr. Sadhu. This is from the Pediatric Epilepsy Surgery Center, SICC Hospital. So this is the case history. She is a 6-year-old girl who was born out of third-degree consanguineous hemorrhage, who had a normal birth and motor development. By taking history, we found there was a mild pre-existing speech delay, but otherwise she was social and verbal. Then at 5 years of age, she had a regression of milestones, like she developed autistic features. She stopped responding to me, self-talking was there, but she was non-verbal and almost she was in her own world. So we can clearly see there was a regression of milestones before even the starting of her seizures. Her seizure started 2 months later after this regression, and her first seizure was a brief generalized clonic seizure, which lasted less than a minute. Then within a month only, she started getting daily seizures, which was happening both in awake and sleep. And the semiology was generalized tonic seizure. There was no aura, there was no any focality. Then she was tried on multiple anti-seizure medications. Even she was on behavioral medications for her behavior. In due course, her behavior also progressively worsened and the seizures continued. She became very aggressive, very weak. At this point, she had come to her. So that point, it was a like an explosive onset medically refractory epilepsy with preceding neurobehavioral regression. So our working hypothesis at that point was she had a late onset epilepsy, but there was an early onset developmental delay and worsening preceded epilepsy. So at this point, we had a clinical diagnosis of whether she is having developmental and epileptic encephalopathy, right? And very likely a genetic cause. So then at this point, we started our epilepsy pre-surgical workup, like medically refractory epilepsy workup, which is an MRI. She did not have MRI at that point. So we did an MRI, we did a video EEG and the neuropsychology assessment. I'll go through one by one. So our video we showed interval discharges. So here we can clearly see there was no normal sleep background. And we can see there is frontal delta slowing, bifrontal, and both bifrontal needle-like spike, polyspike, and Stovey discharges. Little bit the amplitude was more on the left side. Other than that, it was bifrontal and synchronous all the time. And we had rhythmic delta wave discharges, and also we had a generalized spike and polyspike wave discharges. That was also more dominant over the left, but dominant like frontally dominant discharge. This is the ictal EEG that we captured. She had a generalized tonic seizure, and we could find actually in the video when we captured, she had some hyperkinetic movements in the end of the generalized tonic. So this is the ictal EEG showing the generalized paroxysmal fast activity, and which was not lateralizing or localizing So with the video EEG, we could find she had more of the generalized pathology only we could find, but except the left dominant because of the amplitude. And left frontocentral spikes, polyspikes, delta waves, very prominent generalized spike and polyspike wave discharges, no normal background. So with this, we thought this is again like this is suggestive of an epileptic encephalopathy pattern with no normal background. And MRI we did. So here what we found was this lesion. This is a flare image showing hyperintense lesion over the left basifrontal region involving gyri recti and the medial orbital gyrus. This is the diffusion images, but there is no diffusion restriction of this lesion. And this is the T2 coronal image showing the lesion and the same. But if you see, there is a more like CSF intensity over the very mesial region. And this first image is showing T1 sagittal section, which is showing the extent of the lesion, which clearly shows involving the gyri recti and the mesial orbital gyrus. But if we little bit, if we see the part of the tumor was involving even the corpus callosum. This is one thing which was unusual that we usually see that our differentials when we started, like when we first look at the lesion was whether it is DNET or if it is a focal cortical dysplasia. So focal cortical dysplasia was very the least in our list. But in case of DNET, we did not get that specific that focal appearance, or usually those kind of DNETs will involve cortical and subcortical regions. But this one part was a little bit doubtful whether it is going towards any high grade. But otherwise, we did not have any contrast enhancement of the lesion. And this is a high intensity T2 images, which is clearly showing there is a cystic component inside this lesion, which we can see sections. And this is the SWI image, which is showing there is no hemorrhage or calcium. So after seeing all these sequences, we had our first diagnosis of either it is some ganglioglioma or if it is a DNET. So then we went ahead, actually did a genetics also because of the third degree consanguinity and also the flavor of that she had regression followed by epilepsy. So all these we did a whole exome sequencing, but she did not fit this. The genetic report is negative. So this is the summary of the pre-surgical evaluation. EEG was showing epileptic encephalopathy with no normal background. Interictal was showing left-sided dominance, and ictal was showing generalized fast activity, which is typical of a generalized tonic seizure. So these were all still was giving us a generalized pathology types. But after seeing this MRI, obviously it is a left basic frontal tumor. And neuropsychology, IQ was 73, and she had autistic spectrum disorder. She fulfilled the criteria. Whole exome sequence was negative. So these 3 points we would want to highlight. These were our discussion points during our epilepsy surgery meeting. Because a LIAC causing an epileptic encephalopathy, that too regression preceding the epilepsy, is very, very unusual. We couldn't find any case reports so far. And whether we are dealing with dual pathology like LIAC and DE together on a genetic basis. And also, well, the resection of this lesion will really help the epilepsy, whether we will be able to give a seizure freedom and whether the regression will improve. These were our questions. So after discussing with our multidisciplinary team in our epilepsy surgery meeting, as it was a clear-cut lesion, and we all know that when we see a lesion, we have to go ahead with the resection. That is what we are following right now. But we planned for echo-guided resection, and also it was a non-eloquent cortex with no other added challenges. So we counseled the family accordingly. So limitations of the genetic test we told that can be a false negative, and also the resection may or may not improve seizures. So after acceptance from the family, we went ahead with the surgery. So this is our post-op CT, which is showing we have removed almost a whole tumor. This is the post-operative blood that we are seeing. So histopathology showed this is a low-grade glial or glioneuronal tumor. And if we see in the comments, we can see they could not specify exactly what glial or glioneuronal tumor it is. It's
Kavya,
like
can you end? Actually, Kavya, can you
Yes.
end it?
Okay.
Because Dr. Musa is on clinical duty and he has to leave.
Okay.
We've crossed time by 18 minutes, and I want take-home messages. So you can give your take-home
Yes.
messages because I want everybody's take-home messages. Sorry. Yeah.
Yes,
You want to
got
give
it.
out Dr.
Yeah.
Dr. Praganya can give the take-home messages. Dr. Praganya, you want to do that?
Yeah, sure,
Yeah,
Shefali.
Dr. Musa has to just a minute because
No,
Dr.
I
Musa
understand.
has to leave. He is
Yeah.
actually he's on the clinical this week, but he took
No,
out
fair.
90 minutes. We've already taken much more than that, and everybody else also. Yeah, please just
Sure.
can
No,
you stop sharing the
thanks.
screen, beta?
Yeah. Yes. Yes.
Yeah. Thank you. So the reason to present this was just how a LIAT presented very unusually, mimicked genetic epileptic encephalopathy. And even the histopathology came back very unusual. It's impossible to fit it into the latest WHO classification. So it's just about keeping an open mind, like Dr. Musa said, of the three, the EEG, the clinical EEG or MRI, if there is an element of focality, it might help to go after it in selected cases. So that was the take-home message here.
Thank you so much. Thanks for a wonderful case and wonderful presentation. Thank you all for staying so late. Now I'll request them for giving take-home messages, and you can involve the comment for Praganya's case as well. Dr. Musa, please. Your take-home messages for the entire presentation and any comment for Praganya's case.
Yeah, I think, yeah, you can hear me. Thank you, Dr. Kavya and Dr. Pradanya for presenting the case. Very unusual location for LIAT in this age. And any location early enough onset, it's an early brain lesion, during a developing brain can produce epileptic encephalopathy. Great case there. My take-home messages are, one should consider epilepsy surgery as soon as it is indicated. When it is indicated, you fail 2 medications, disabling seizures, you think about it. If there is a non-eloquent lesion in the non-eloquent area, that is unlikely to remit on its own. Obviously, most lesions do not remit on their own. You should consider surgery even sooner. And the number 2 is focality. You look for focality. If you have focality in semiology, focality in EEG, and focality on the MRI scan, so you need one of these to be present to consider epilepsy surgery. It kind of applies for all the epilepsy surgical candidates. I'm talking about resective epilepsy surgery in particular here. I think those are my main messages.
So much. Thank you so much. I know you have to go back for the clinical work and you took an early round. Thank you very much. Grateful to you. And I come to Dr. Krishna Prabhu. You have not, now you'll have to make comments, the take-home messages for us, but all the comments you have for the 3 cases, sir. Dr. Krishna Prabhu, from a neurosurgical point of view,
Yeah, I think the third case, I just want to know what is the outcome. I mean, we didn't get the full picture. What are the follow-up?
So she's, Kavya, go ahead.
Now it's a 10 months follow-up, sir, in the 1A seizure, no seizures till now, and completely her behavior has changed. She regained her social smile, started speaking, and now she's good.
Sure. Okay. Now that's a good case. I mean, that's a good outcome. Only thing is, I was concerned whether should have gone for a fronto-basal disconnection, but anyway, that's fine. It's gone out well. My take-home message is that, most of these, once localized, I mean, from a neurosurgical point of view, if the lesion is localized very well, we can excise it. I mean, we can excise it with both ECOG and as well as navigation. And navigation plays a very, very important tool for us. It's a very important tool for us to go all out and, go for a radical excision. So from neurosurgical point of view, yes, we need to be very clear. We need to know the define the lesion, and then go forward. And navigation is a great tool, and we use routinely for all the cases navigation, or of course along with ECOG and thing. But navigation is also what I recommend, that navigation should be utilized for all the cases.
So anything you want to say for Lokesh Saini's case from Jodhpur and Ranjit's case?
Yeah, the Ranjit's case is also very good. I mean, the posterior coronary resection was excellent. That it is excellently done, and it's come out with an excellent outcome. The point I want to make is, like, for the posterior coronary, the surgery procedure. The only thing is you should be as close to the motor cortex as possible, but say 1 gyrus behind. So if you can do that, you will get a good excision and good resection and a good seizure outcome. The first case was, I think it is from surgical point of view, it is straightforward. I don't think it is anything different. I think from the epileptologist evaluation, of course, it's quite challenging, but from a surgical point of view, I think it is straightforward surgical excision. Yeah,
Thank you, sir.
I think my role is very simple and easy. I mean, I think my colleague Dr. Maya does all the hard work and toil of localizing the lesion and working it from. So for me, it's almost on the platter for me to go and exercise it or do a surgery.
Thank you so much. Dr. Lagandhi, your take-home messages.
Yeah, what I found very nice in the cases is the fact if you have a good semiological analysis, a good EEG analysis, some good MRI analysis, sometimes with post-processing, you can have very good outcome without a need to have very technical or advanced signal analysis or intracranial EEG. So it's very nice illustrations of good outcome in patients with the basic evaluation. So for me, it's the more important point of these cases. So thank you very much for the presentations.
Thank you. Thank you so much, Professor Ebru.
Yes, thank you. I think we're all going to say the same thing. These children with focal epilepsy, if you suspect of a lesion, you should directly refer to the epilepsy center, a specialized epilepsy center, and therefore, consequently, you're going to avoid the long-term consequences and morbidity of the epilepsy. And if you don't have a resectable lesion, the palliative procedures like corpus callosotomy should also be in our mind, I think. Our neurosurgeons also think like that. Thank you for this lecture. Great lecture.
Thank you. Dr. Kothari.
So I think I'll echo exactly what the others have said, the other panelists have said. Very, very nicely done. I just want to emphasize for Dr. Gadgil her case that do the BRAF mutation, and even otherwise, please do the tumor surveillance. That means every 6 monthly MRIs for the next 2 to 3 years, and then every yearly subsequently for the next 5 years. These tumors are notorious for coming back. And there was a very famous case involved in Massachusetts where, when I was at Harvard Medical School, this case, very similar presentation, presented with a right-sided DNET with the infantile spasms. We excised it, and the tumor came back 3 years later. After being completely in remission with complete removal of the tumor, and it came back, and outcome was terrible. There was a bleed during surgery. There was a stroke subsequent to that. So I would definitely recommend doing, and tumor surveillance has become the standard of care now. It wasn't the standard of care 15 years ago, but it is a standard of care today. So please do tumor surveillance.
Yeah, no, absolutely. So we did a BRAF mutation. I think that we couldn't show that she is negative for the mutation. And we have a neuro-oncology MDT as well. So now this girl is plugged into the neuro-oncology surveillance as well. But absolutely.
Thank you. Dr. Patil, say something?
Yeah, I think the talks, all the 3 talks, presentations were excellent and covered different aspects of refractory epilepsy with hypoglycemic brain injury, and again the very unusual case from Pradnya's team. I think the take-home messages were very clear with focal epilepsy, focal semiology, focality on a MRI. Do consider epilepsy surgery as early as possible. You need not wait for things to become refractory and resistant. And obviously, whenever possible, go ahead with a simple investigation tools like video EEG and MRI. And if not, then probably you can go ahead with a stereo EEG, PET scan and all, where the facilities are available.
Thank you. Thank you so much. Mahesh, you want to say something?
Very nice decision today, ma'am. One more point I was like, in India, we have many of these hemisphere pathologies. They are the video response to functional hemispherotomy. And we did almost about 20 cases. We got more than 80-90% results in the functional hemispherotomy. So that was an important surgery to be considered. It can be done without much of workup also. In an hemispherotomy window, functional hemispherotomy.
Yeah, I think one big thing is what everybody's been saying, and we should remember that we should think early. We should think early and not keep sticking on to ASMs. That is what think go back. Thank you, everyone, for sparing you so much valuable time and experience. And I think everybody must have benefited a lot. I just wanted to remind you for the 70th AOCCN next year, 17th to 20th September 2025 in New Delhi. The registrations are open and the registration links will be mailed to. Thank you so much. And good day and good evening and good night. Yes. Thank you. Bye.
Thank you. Good night,
Thank you.
everyone.
Bye.
Dr. Shefali.
Good evening.